As we move on to our next speaker here, I'm going to bring Dr. Jenny Chen on. Hey, Jenny, how are you? And I'm going to get your slides up here too. Perfect. So Jenny, you want to do a quick introduction of yourself? Actually, before you do that, I want to remind the audience, you are welcome to put comments, particularly the Facebook and the YouTube stream. The comments come in really nicely for us. We got a nice comment earlier about Happy World Day of Regional Anesthesia. And Dr. Haskins giving Dr. Ume a nice shout out there. So thank you everybody for participating in the conversation. Put your questions in the comment box. Also just tell us where you're listening from. Where in the world are you that you're listening to our live stream? We'd love to see it. So just type that into the comment box. Jenny, now let's get to you. You want to give a quick introduction of yourself and then we'll get to your presentation.
Awesome. Thank you so much, Raj and Rakesh, for inviting me. I'm so honored to be here. And Uchenna, thank you for that awesome presentation. I love learning from everybody, and I'm cleared my whole day for this. This is awesome. Good morning, everybody. My name is Jenny. I'm a regional anesthesiologist at OHSU in Portland. I'm also a chronic pain physician, and I spend about half my time at the pain clinic at the South Waterfront. I'm honored to be here to talk about when blocks go wrong, managing postoperative neurological symptoms. This topic is near and dear to my heart because these are my favorite patients to see in pain clinic. And also because I firmly believe that this is such an important way that we can prevent harm in regional anesthesia is to correctly diagnose and attribute neurological symptoms after surgery and to prevent further patient harm.
Well, Jenny, we'll let you take over the slides and continue the presentation. Thank you for being here.
Thank you. All right, let's see. First, we'll talk about the incidence and pathophysiology of nerve injury and postoperative neurological symptoms, which, if I remember, I will abbreviate to PONS. We'll talk about reducing risk for nerve blocks and then spend the half of the presentation talking about the diagnosis and management of PONS. So the risk for severe peripheral nerve injury after surgery is luckily extremely low. The etiology of peripheral nerve injury is in the perioperative period is complex, multifactorial, still remains pretty incompletely understood. Our best studies to date tell us that peripheral nerve injury is associated with general anesthesia, hypertension, and smoking. It's also associated with certain types of surgery, with cardiac, orthopedic, and neurological surgery carrying the greatest risk. Surgical contributing factors include just creating a very pro-inflammatory state, patient positioning, anything that causes traction on the nerves, compression, ischemia, contusion of the nerves, and tourniquet use. So when patients ask, what is my risk of peripheral nerve injury after surgery? I tell them that it's lower than my chance of getting into a car accident while driving home from work. But it's not zero because we still don't completely understand it. Patients can also have postoperative neurological symptoms after regional anesthesia, which can be defined as new onset neurological symptoms, either sensory motor weakness or dysesthesias, in the distribution of the peripheral nerve block, either directly attributable to the block when reported or reported in the context of regional anesthesia in general. So when patients ask, what is my risk for PONS after regional anesthesia? My answer is it depends. It can be fairly frequent for residual numbness and tingling as your block wears off or sets up, or it can be less frequent, around 15%, that you may have a prolonged block over the next 24 or 48 hours. The risk of long-lasting injury is, again, very low. The overall incidence is low and also decreases over time. This is from a really great review in 2024 published in RAPM. This study gives the incidence of PONS as being approximately 1% at around 2 weeks timeline, which decreases to about 0.03% at 1 year. This is really similar to the rate of overall peripheral nerve injury after surgery from that really nice University of Michigan study in 2009, which included all patients, even people who didn't receive peripheral nerve blocks. So we know that peripheral nerve blocks are very safe, and for the most part, our bodies are pretty good at recovering from that transient injury, but we know that nerve injuries still occur. The epidemiological triangle, as you see here, is an injury model that we use to describe the relationship between an agent, host, the environment. Um, Mechanisms can further be divided into four broad categories: mechanical, pressure, chemical, and vascular injuries to the nerves. The safest approach overall seems to be identifying prevention of as many potential risk factors to neurological injury as possible. So we mitigate these risks by minimizing injury to the perineurium covering the nerves, judiciously exposing axonal structures to pressure or chemicals, minimizing trauma to vasculature, and being as fastidious as possible in terms of nerve and needle identification. So the diagnosis of PONS is based on symptoms, history, and physical exam. Early recognition of nerve injury and prompt risk stratification to prioritize those patients that require urgent attention is essential to give our patients the best chance of neurological recovery. Recognition of nerve injury may be difficult where excessive sedation or postoperative pain limits the examination. Um, Also, continuous peripheral nerve block catheters can mask PONS for days, uh, or in ambulatory patients who are lost to follow up. They're kind of hard to catch. So I have a higher index of suspicion with catheters, surgical nerve blocks, if there's any evidence of nerve swelling on ultrasound, high injection pressures, multiple attempts or multiple needle passes, and paresthesias during placement. Having said that, case reports in our best studies tell us that most of the nerve injuries that are reported and recognized happen without any recognized complications at the time of the nerve block. So you can have a perfect anesthetic, a perfect nerve block, and still have neurological injury afterwards. So symptoms of the nerve injury can present acutely when the block recedes or may become apparent to several days or several weeks afterwards. And symptoms vary depending on the origin and severity of the injury, and it can range from mild intermittent tingling and numbness to more severe, persistent, painful paresthesias, sensory loss, motor weakness, or both. We know that combined sensory motor and pure motor deficits are the most common. Pure sensory deficits are rare, but probably underreported. So when patients ask if I have residual numbness or motor weakness, who do I talk to? They can talk to their surgeons because that's usually the only service where they have scheduled follow up. They can tell their primary care provider, who is a great coordinator of their care. Ideally, they would have a direct way to get a message to the anesthesiology service that performed their nerve block. At our institution, we have a robust acute pain service that's staffed by regional anesthesiologists, chronic pain attendings, fellows, and residents. This is a snapshot of a patient discharge summary where we give them the number for the on-call APS physician if they run into any problems. And they can call that number 24/7. And this really illustrates how important a service we provide to the patients when we have acute pain trained physicians. So this is the algorithm for the diagnosis and initial therapy of periop nerve injuries from ASRA, updated in 2015. I really like this algorithm because it helps with risk stratification. Um, So it separates into emergent situations and situations where you have a little more time. So in the case of suspected space-occupying lesions associated with neuraxial nerve blocks, we treat this as an emergency because the patients can have rapidly evolving neurological symptoms that may or may not be fully reversible. For complete or for progressive, really bothersome peripheral nerve deficits, Both the surgery and anesthesia teams should be notified, and workup should be expedited to allow identification of potentially reversible factors, such as extrinsic or intrinsic compression of the nerves. So, is there a tight cast or a dressing that needs to be released? Do we need to pay attention to the possibility of compartment syndrome or hematomas? Our acute pain service sees these patients in-house, or I offer urgent appointments in pain clinic for our patients who are at home. Imaging may be useful to define if there's a lesion or an acute process very early on, rule out hematomas. Electromyography or nerve conduction studies early at less than 7 or 10 days can be really helpful in localizing and separating conduction block from axonal injury, so neuropraxia from axonotmesis. These studies won't provide much more diagnostic information beyond that at this early stage, but there is a role for electrodiagnostic studies at this early time. Um, for patients who are having mild to moderate PONS, the decision to follow up or not depends on the severity and duration of symptoms, and this is a great opportunity to do some shared decision making with the patient. So when they ask, do I need to follow up about these symptoms? At our academic institution, we encourage all known symptoms to be followed up initially via a phone call from the regional anesthesia team. I also encourage them to follow up with either their primary care provider, their surgeon, if they would rather go that route. Um, if the symptoms persist, a physical exam is really important. Um, if the physical exam shows just mild symptoms, then reassurance, empathetic connection with your patients is really key to alleviating patient anxiety. Um, I also offer follow-up within a couple weeks to review the need for further diagnostic tests. If patients are very anxious, I offer more frequent follow-up or check-in phone calls earlier. If there's any motor involvement, difficulty in localizing the injury with the expected distribution of the nerve block, if I think there's anything else going on, if there's complete absence of nerve function beyond the duration of the peripheral nerve block or any severe functional limitations or progressive deficits, then an early pain or neurology consult is definitely needed for those patients. My goal in these situations is to be as accessible to these patients as possible from a follow-up perspective. I want them to turn me away if they don't need me. So when patients come to follow up and ask, what can you do for me? I tell them that we have two goals. One is to investigate the underlying cause, and two is to treat symptoms of pain and dysfunction. Um, EMG, or electromyography, and nerve conduction studies can be really great tools in the subacute period. Um, EMG studies look at electrical activity generated within a muscle, and they can determine the muscle units affected by the injury. 3 or 4 weeks after injury, you can see fibrillation potentials on EMG. That can be a sign that there's denervation going on. Um, you can use nerve conduction studies to localize the site of the conduction block, and that may be really helpful in confirming or refuting that the nerve injury is consistent with a peripheral nerve block injury. Peripheral nerves are very nicely topographically conserved, meaning that they have a really consistent internal fascicular organization, and that helps with lesion localization and to guide targeted repairs if those are needed. It may not always be possible to distinguish between anesthesia and surgery-related causes when the surgical incision site, the block site, and the tourniquet are all in close proximity. But these studies can help. Electrophysiology studies can also offer prognostic information depending on the degree of injury found on examination. Now, if there is a known nerve injury, a nerve injection, or an intraneural injection, we may wait to get the EMG at a couple of months just to document recovery and decide next steps. In the meantime, we can always use non-opioid analgesics to treat pain. And if there is dysfunction, connecting them to physical therapy, occupational therapy, or physical medicine. So what can be done if I don't get better is a question I hear from patients often. So unfortunately, no pharmacological therapy has been demonstrated to enhance neuroregeneration, but we still have some pretty good treatments for the sequelae. Um, Treatments involve physical therapy to maintain muscle mass and prevent flexion contractures. Um, we can also use pain medications. We can escalate up the analgesic ladder and escalate these medications to therapeutic effect. When there's incomplete or there's no improvement by about 3 or 5 months, that's when we think about repair, and we can refer to a peripheral nerve surgeon, plastic surgery or neurosurgery, to talk about surgical techniques. And there's really cool research coming up in restoration of neuromuscular function by either neuromodulation or brain-machine interfaces. Um, that's going to be really cool coming down the road. So in summary, most postoperative nerve injuries are unrelated to regional anesthesia, but postoperative neurological symptoms should be evaluated early for reversible factors. Reassurance is extremely important for mild symptoms. Risk of permanent PONS is pretty low, and management for persistent PONS is multidisciplinary and can include imaging, electrodiagnostic studies, medications therapy, and definitive surgery if needed. Thank you guys so much for your kind attention.
Thank you.
These are the 4 little reasons why my voice sounds a little hoarse today.
Wonderful.
Yeah, thanks for the amazing presentation, Jenny. I had one question myself. In your practice, what major complications are often dismissed early on as insignificant, and which practitioners should pay more attention when patient reports with PONS? Do you have any guidance to practitioners?
Yeah, I think overall, as anesthesiologists, we're really good at catching red flags early. I think where we run into problems is when we don't have access or follow-up to our patients. And that can sometimes come from our surgery colleagues as a way to not bother us, right? If they have a patient with a wrist drop or a foot drop after surgery, the surgeons can reassure these patients and say that this will get better. It usually gets better, and then they don't want to bother us by telling us about it. And I think we need to have more communication with our surgeons, because if that happens, it's better for us to know about it earlier than not. And that way we can follow up and just make sure that things don't get lost to follow up, that we can order diagnostic tests early and we can just stay on top of things.
And how do practitioners, do you have any words of advice how practitioners reach out back to the surgeons and still convince them to go ahead and access blocks when bad events happen? Do you have any thoughts on that?
Yeah, I think relationships are so important. It's definitely a delicate conversation to have, especially when things go wrong. It really helps when things go wrong to come together as a team and really talk about the different factors. Um, I think that we do so much good in regional anesthesia um, that uh, that we really need to have, um, I guess, productive conversations around when things go wrong, and keep in mind that it's important for us to really delve down into the root causes of these postoperative neurological symptoms and not just let everything get blamed by anesthesia, because our best evidence tells us that 9 times out of 10, a postoperative neurological complication is attributable to the surgery and not the anesthesia itself.
Jenny, thank you so much. This topic is obviously weighs heavily on most of our minds as we're doing regional anesthetics. None of us want to cause harm to our patients in the process, but I think we have to have our eyes open that these things can happen, and good communication, good preparation is critical. Thank you so much for joining us for this presentation. And, like I said to our audience, keep throwing in questions. I think there was a comment that the surgeons don't want to bother us about neurologic complications. That's such an important insight, is that open line of communication is so important to making this work properly, both directions. It has to go both ways. So thank you so much, Jenny. Appreciate having you here.